A very warm welcome to Global Healthcast 41, brought to you by Global Health Press. Once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. Great you're joining us. I am Joe Schmitt, and as always, with me is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, and good morning, good afternoon, or good evening to people who are watching us today.
We recently covered dengue and dengue vaccines in 3 specials, and today we're back in our usual general topics on infectious diseases and vaccines. The agenda is a review of the global COVID-19 situation. We go on with our most infectious diseases, covering disease X today. Then we will hear about blood group A and SARS-CoV-2 infection. There is a connection. And finally, we will discuss which organism may cause the next pandemic. We know that it will come. We don't know when, and we don't know the organism. So stay tuned. And we start, as always, with the COVID-19 situation. Melvin, what's the situation on the globe?
Yes, so we have not shown you this specific image for a while now because, as we've said, the COVID the emergency part of the pandemic has ended, right? And so we said that we will try to cover other topics, but just to show you that this is the situation now globally. So as you can see here, the cases and deaths have dramatically gone down. But again, it's also good to remind people that the cases reported are not an accurate representation of infection rates because of reductions of testing and reduction of reporting globally. But the next slide will show you a more detailed version of that bigger global situation. Here you will see clearly that in all the regions, the WHO regions, right? So we talk about the Americas, which is Latin America, the Southeast Asia, Europe, Mediterranean, and so on and so forth. You will see really that all of the regions have reduced their numbers of cases and deaths dramatically since the beginning of the year, January here. So it's a good sign. It's a good thing. And I was in Marseille in the south of France yesterday and several days ago. And I think like almost everywhere in Europe, people are not doing any precautions anymore. No more masks, no more physical distancing. Basically, we can say that people have stopped doing all these COVID precautions that we've been doing for the past 3 years. Professor, any comments on that?
I'm with you. And I'm just wondering, number one, this is 90% of the world population live on the Northern Hemisphere. And I think it is summer in Europe, so the cases are going down just because it is warmer. And we always have this in summer. We have fewer cases for whatever reason. We don't know. But then looking at Africa, it is also going down. The question then is, what is the reporting there? In Australia and South Africa, there is winter now. The question is, are cases going down there, or are they about the same? Are they going up? Is there any information? Maybe we cover this next time.
Yeah, so just a quick answer to that. In Australia and in Brazil, which the countries that have opposite of the Northern Hemisphere, right?
Right.
Of course, there are spikes in flu, in RSV, in COVID, but it's not like the COVID pandemic spikes that we've seen in the past 3 years.
Okay, so there is a little increase, but it's not dramatic, and the disease is quite mild now, right? We don't have the some percent of deaths that we had in the beginning of the pandemic. So this is a different situation.
That's right, yeah. Yes, and we always have been showing you this map as well, and this is showing us the percentage change in confirmed COVID cases in the last 28 days. And if you look at this map at the country level, the highest numbers of cases were reported from the Republic of Korea, from Australia. Just your question about what is happening in Australia. Brazil is number 3. also your question about what is happening in the Southern Hemisphere. And also for the first time, Singapore is number 4 in terms of uh, increase in cases. And then the last is Russia. So these are the top 5 in terms of cases for the last 28 days.
Yeah, and this is all based on very low numbers in the end, right? It is not that many cases that we saw before. Interesting. Yeah.
Yep.
And how about deaths?
And so in terms of deaths, the top 5 countries are Brazil, the Russian Federation, Italy, Peru, and Australia. So if you notice, Brazil and Russia, they were mentioned in the previous slide with the top 5 highest number of cases. And the other countries, so Italy, Peru, and Australia, Italy and Peru, they were not mentioned, and Australia, of course, was also part of the previous slide. So I guess there is something in these other countries where the increased number of cases does not necessarily translate to increased number of deaths.
Okay, interesting.
It could be vaccination coverage. It could be their number of people with comorbidities, age, and many others.
Yeah. Interesting map. Still, after it is gone, it is nice to look at that and try to understand what is going on. Melvin, very initially in the pandemic, we learned that coronavirus bind via a special receptor, the ACE receptor, and there was a lot of concern about blood pressure and if you could even treat coronavirus with receptor blocking agents, right?
Yeah.
But now you have something interesting on the blood grouping and SARS-CoV-2 infection.
Yeah. So this is from researchers from the Brigham and Women's Hospital in Boston. They studied the receptor binding domain, or the RBD, of SARS-CoV-2. So this is the domain that facilitates host cell engagement. So the RBD bears significant similarity to the galactins or the lectin. It's an ancient family of carbohydrate binding proteins. So as this ABO blood group, so we know the blood type A, B, and O, right? These antigens are also carbohydrates. Researchers compared the glycan binding specificity of the SARS-CoV-2 RBD with these galactins. And they found out that in the study that the RBDs of the SARS-CoV-2 virus exhibits specificity for blood group A. And not only did each RBD recognize blood group A in a glycan array, but each SARS-CoV-2 virus also displayed a preferential ability to infect blood group A expressing cells. So a lot of technical terms, but the bottom line is that in this study that they have done, they have shown that blood group A enhances infection of SARS-CoV-2 as compared to the other blood types like B or O.
Yeah. So the interesting question to me then would be, where are these galactins presented on the mucosal surface? If they are on a red blood cell, I don't worry about, right? It is in my blood, but this is not where I get infected. I would get infected at the mucosal membrane. Are they expressed on mucosal membranes?
I would imagine that this only happens once the virus has already entered the system, right? Because the blood is in the system, right? I don't think that it has some expression in the mucosa, but this is something that these researchers will for sure look into as a future research topic.
Yeah, I mean, it would be nice to block infection, right? If you have a vaccine that would block the receptors, or then you would reduce transmission. You would reduce carrier chain transmission. So that would be really something nice. Or if you have a medication that prevents infection by blocking the receptors, right?
Yeah, and I think a lot of groups are studying how nasal vaccines can potentially help in this regard, right? Because technically, when you have a nasal vaccine and you focus on the nasal mucosa, you might induce some neutralizing antibodies over there that would prevent infection. So
Yeah. Interesting topic. I would have a lot of arguments to say about nasal vaccines or oral vaccines even, and why they have not been successful so far, with the exception of oral polio vaccine. That is the only exception I know. And then there is this live attenuated influenza vaccine, which is working well, and the typhoid vaccine then has some efficacy as well. But overall, for pertussis and some other antigens, it has not really worked well. So concerns that oral and intranasal vaccines have not universally been successful. And maybe you wanted to say something on that.
well, I mentioned that we also have an intranasal flu vaccine, but with
Yeah,
all the vaccine development efforts in the past, it's always the bioavailability.
yeah.
For example, for oral, it's destroyed by the stomach acids and enzymes and all these things, right? And that's why we are saying that really the easiest way, I would imagine, is the intramuscular or subcutaneous vaccines, because they don't have to go through all the other parts of the body.
Yeah. Very good. Now we are going to the next big topic, which is our most infectious diseases that WHO identified. And this is what we covered.
Yeah, so we've been covering all these different diseases since the Global Health Cast 33. So if you are interested to know more about the Nipah virus, the Crimean Congo hemorrhagic fever, and so on and so forth, you can just look at all these different Global Health Casts in the past. But today we will be covering Disease X. And maybe you are interested to know what Disease X is, but basically when we say Disease X, it's really any unknown pathogen that could potentially cause a future outbreak. It could be a virus, it could be a bacteria, maybe less of a, maybe for a fungus is maybe less uh, of a possibility, but a bacteria or a virus is more probable to cause a disease X. And so what is disease X, right? So we are really interested to know what that could be. And Professor, what do you think? Do you have any thoughts on what this could be?
Yes, and I put them into some slides. So my first thought is we have to look into pathogens that are easily transmissible. If there is no person-to-person spread, then it is very difficult to cause a pandemic. And the most easily transmissible pathogens are those that cause acute respiratory tract infections, ARI. So I predict the next pandemic will again be caused by a respiratory pathogen. What you see here, humans get sick on average 10 times a year, 6 times it's a respiratory infection. And the next most frequent cause of infectious diseases is diarrhea, with only a quarter of the cases of respiratory tract infections. So again, this is what it will be. Now, the question then is, what are respiratory pathogens? And you can divide them into colonizing bacteria that are beta-lactam sensitive. Streptococcus pneumonia is the most prominent and most important one, but they are very stable. They will not change their immune surface, and I don't think they will cause the next pandemic. Then there are these non-colonizing bacteria that are macrolide sensitive. They do cause outbreaks and they do cause epidemics and even more regional epidemics. They're usually like mycoplasma. Every 3 to 5 years, they come down from Copenhagen down to Rome. They travel down through Europe, and again, these are pathogens as well, but not a pandemic, right? We know how to live with them. We know how to treat them. So this is not what I consider any organism to cause a future pandemic. But then there is this large list of epidemic viruses, at least 14 group of families that I've listed here. And SARS-CoV-1, RSV, parainfluenza viruses, 1, 2, 3, 4, enterovirus, and so on and so forth. And they regularly change their surface epitopes. And since they can do this, there is immune evasion. So each time they change their surface, your immune system sees there is a new virus. Then there is high frequency person-to-person spread that I showed you in the last slide, right? We get 6 times a year with a respiratory tract infection, and that is the group of organisms that is causing this. And then most of them, if not all, have an animal reservoir. So at any time from an animal virus, they may change and jump to humans to become a human virus with a large case fatality rate and with easy transmissibility. So this is what I would worry about. It is these epidemic viruses. Now, the very predictable one is influenza. We have had influenza pandemics in 1918, 1957, 1968, 77, 2009. Here are the designation. Here are the antigens. We had H1N1, H2N1, which is the hemagglutinin and neuraminidase antigens, H3 and 2. And then in 2009, we had this H1N1, you may remember, and this was the pandemic here. And it's easy to predict that there will be another influenza pandemic. And again, it happens every 10 to 30 years. And one that we covered already in one of our global halfcasts a couple of weeks ago is H5N1. We know that this virus is already getting ready for a pandemic with some changes that have occurred. Some more changes need to occur, and go back and look at our previous global halfcast, and you will hear more about H5N1. So I think, I'm not sure if it is H5N1, it may be different, it may be an H7, whatever, N1, but there will be a next influenza pandemic, that is sure. The next thing that I think is sure is coronavirus. Here you have the classification of the coronavirus. That is not that much interesting. For you to remember, it is an RNA virus infecting birds and mammals. So we have an animal reservoir. There are these endemic human coronaviruses, which have been known since the 1960s, that usually cause very mild respiratory infections. And they have these laboratory designations. They don't even have a real name. KHU1, OC43, whatever, don't remember the names. They're out there and they cause disease, but usually very mild, and they will not cause a pandemic because humans already spread them and there is not much disease around. But the pandemic potential we had seen in the past is animal coronaviruses jumping to humans. There was the Guangdong epidemic in 2002. There was the dromedar pandemic. The dromedars are the reservoir. The MERS, the Middle East Respiratory Syndrome coronavirus 2012. And then we had COVID starting in 2019. So looking at this 2002, 2012, 2019, it is easy to predict the next would be 2026 to 2029. I wouldn't bet my monthly salary on the year when it will be, but I bet there are more animal coronavirus out there ready to jump to humans. We don't know when it will happen, but I would predict it will happen in the near future, and we should be ready for that. Now, WHO, and Melvin was nicely covering this over the last weeks and months, has this list: Ebola virus, Lassa virus, the most infectious pathogens with a public health emergency of international concern potential. But I don't think any of these will cause a pandemic. This is a political agenda list. WHO wants to tell us, get ready. Get your laboratories ready, keep them busy. They need to practice now for the pandemic to come. The real pandemic, and here WHO agrees with what I just showed you, they think that the next pandemic is a respiratory pathogen, caused by a respiratory pathogen. And they ask for systemic coordination and cooperation with sustained investments for financing, monitoring, and being ready for a next pandemic. And again, the preparation, the exercise, the practice every day should be on the 8 pathogens that Melvin had been covering. There is one other concern that I have. I'm not sure if this is a real story or if this is an unjustified concern. I just want to bring it up because we must not forget about it. It was in the 1980s that the Soviet Union expanded its bioweapons research program and was eventually able to weaponize smallpox. So they do have the smallpox virus as a bioterrorism organism. And when the Soviet Union collapsed, there were many, many researchers that disappeared. And for many of the stocks that were owned in the Soviet, that were stored in the Soviet Union at the time, we don't know what their whereabouts are. And there is a concern, and that is not only from myself, but from more knowledgeable people, like in this publication. So the concern remains that somewhere, somehow, the variola virus might be kept illegitimately in secret stocks. And this may cause a public health emergency of global concern because we're no longer vaccinated against smallpox. There is a smallpox vaccine out there, and there are actually several, I would assume, but we need to be ready for this potential threat as well. At least we should think about it and be ready to face the situation where smallpox comes up again. Melvin, what is your view on my pandemic pathogens of the future?
Yes. Firstly, I completely agree, Professor, that it will be a respiratory pathogen because it's the most efficient way or the easiest way of infecting other people. So that's one. I think you covered influenza, coronavirus, and could be orthopox virus, but also keep in mind that there are several other viruses out there that we have not yet discovered. So it could also be something else that's not any of those three, right?
Yeah.
But this is something that I want to highlight. So CEPI, the Coalition for Epidemic Preparedness and Innovations, they're actually looking at this project 100 days. So it means it's an ambitious goal, but technically and scientifically, I think it is possible now with all the technology that we have and with all the innovations out there. They are trying to create a safe and effective vaccine for any of the disease X that we might encounter in the future in a matter of 100 days or roughly 3 to 4 months. This is because studies have been done, like modeling studies, showing that, for example, for the COVID-19 pandemic, if we had vaccines already in the after 100 days, many infections and deaths would have been prevented, which makes sense, right? Because if you have a vaccine in a matter of 3 to 4 months, then several transmission and other infectious cycles and chains would have been broken if we had a vaccine. So this is a very, I would say that this is a very ambitious, but technically it is possible. It could happen.
I totally agree, Melvin. And look here, the vaccine, we had late 2019, COVID started, right? And we had a vaccine basically as of 2021. So only this was preventable. But if we had had the vaccine before, many deaths, which is the black line here, would have been prevented. So the 100-day goal should be possible based on pre-existing technologies and pre-existing protocols and pre-existing factories. If that is all in place, I think this is achievable. We have influenza vaccines seasonally. We need a plan A, which is rapid vaccine production, which is probably an mRNA approach. And then we need a plan B. If that doesn't work for whatever reason, we may use cell culture vaccines and other technologies that are a little bit slower. The issue is that for influenza vaccines, it is all egg-based. Yeah. And egg-based takes too long. You have to order the eggs, and if there is a bird flu pandemic, there are no chicken for the eggs to be produced. We cannot produce any vaccine because there will be no eggs, right? So cell culture technology for influenza is of utmost importance. And certainly if there would be an mRNA approach, that would also be nice. And one last word from me, Melvin. I totally agree as well that in the end, there are 300,000 RNA viruses in animals that potentially could jump to humans. And disease X is disease X, and we don't know what it is. Influenza and corona are two candidates that will cause pandemics in the future. But disease X is the third one that we need to worry about.
Mm.
Very good. I think this was a very nice topic today, and we covered the global COVID-19 epidemiology. We covered disease X and blood group A and SARS-CoV-2. They are connected via a receptor, a galactin. And then again, we discussed the next pandemic and what will be the cause of the next pandemic. This was our Global Healthcast 41 today on July 12th. You will find today's slide presentations in our show notes. Please like, share, and leave your comments below. Thanks for joining us today. I am Joe Schmitt.
And I'm Melvin Sanicas. Thank you, everyone. Stay safe.